Welcome to Health Hour, a session for you by Black doctors, hosted by the Caribbean and African Health Network. Ever sat in a doctor's office thinking, they just don't get it? Or search for health advice online, but you can't understand it? Felt unheard? You're not alone, and you found your solution with Health Hour. Every Saturday at 11 a.m. This is your space where Caribbean and African healthcare professionals speak about health with a focus on Black people. We tackle the topics that keep you up at night: mental health, chronic conditions, preventive care, sexual health, men's health, women's health, heart disease, and much more. All with the cultural context that matters, because our Black doctors understand the unique challenges we face. Here is what you can expect: real talk from doctors who look like you and get it, lived experience testimonies, practical advice, illness prevention and management tips, and a space of understanding without judgment. You also get to ask questions. Your questions drive the conversation. Health Hour, where community meets Black health expertise.
Good morning and welcome to another episode of the Health Hour by CAN. It's lovely to have you with us this morning. Happy Easter to those celebrating, and thank you for sparing some of your Easter weekend to come and listen to the presentation today. We've got a very interesting speaker who I actually had the pleasure of meeting at the International Women's Day that was organized by CAN about 2 or 3 weeks ago. Her name is Dr. Priscilla Djan. She is an obstetric and gynecology clinical fellow, so she's a doctor in obstetrics and gynecology, working towards her way as a consultant. And she's an amazing leader as well. She is a leader of an organization called House of Medics in Manchester, which is a community that supports doctors outside in activities outside their clinical work and keeping that community together. And she's driven by commitment in tackling health inequalities. And amazingly, she's also currently completing her master's in global health at the Liverpool School of Tropical Medicine. Dr. Djan has a passion for human development, particularly focusing on mentoring and inspiring young people from diverse backgrounds into healthcare. And no better person to tackle the topic that we have this morning. And it's a pleasure to have you here, Dr. Priscilla, to take us through the challenges that we're having as a Black community facing the healthcare system. Over to you, Dr. Priscilla.
Thank you so much, Dr. Falake, for that very generous introduction. I always blush a lot because when you read your accolades, you feel like, oh my goodness, it's a lot. But thank you so much for this opportunity. Thank you also to the CAN team for allowing me to come and share a little bit on Black maternal health. So as Dr. Falake mentioned, my name is Dr. Priscilla Djan, and I'm really excited, looking forward to share a bit of knowledge about this topic. So first of all, I'd just like to know if everybody can see my slides. If you can see them, please put a yes in the comments or a thumbs up, please.
Yes, we're good to go. Thank you, Dr. Priscilla.
Perfect. Okay. So just to lay expectations for this talk, what's going to happen is that I will present on this topic for about 30 minutes, and then afterwards I'll take any questions towards the end. If you do have a question that you are dying to ask, just feel free to type it in the chat, and the team will pick up on it and will raise it up to me at the appropriate time. And please be engaging with this as well. I'm sure a lot of people who are joining today have been through just have been pregnant before or know somebody who has been pregnant before, so make sure to just respond in the chat as well. That'd be lovely.
Dr. Priscilla, at the moment we can't see you, unfortunately.
Oh, can you not?
It might be a video. No problem, take your time. Thank you.
Thank you. Can you see me now?
Yes, we can. That's brilliant.
Okay. Thank you so much for that. Okay, so Black maternal health is such a big, huge topic, and it is a hot topic that's been in the media for a very long time as well. Today, what I plan to focus on is four major key topics. So, the key challenges affecting Black women's health during pregnancy and birth, as well as labor and delivery journey, and building confidence through self-advocacy. And I'll touch a little bit on cultural expectations as well. So being pregnant does not come without any risk factors. The next few slides might sound a bit grim and dark, but it is the risk that is out there. Not to mean that no one can have a successful pregnancy, as we all know, but just bear with me as I talk about risk factors and things that need to be considered during pregnancy. General risk factors for anybody who is pregnant include maternal age. Usually anyone age 35 and above who is pregnant, that is considered as a geriatric pregnancy because your body changes, your physiology changes. You may have other health conditions as well in the background before you can become pregnant, and those conditions can be heightened when you're pregnant. A lot of women go through IVF as well, and that again can be a risk factor for later on in pregnancy, just about how the pregnancy develops and making sure that there is extra monitoring that is put in place. The number of pregnancies that you've had is also a risk factor. We know that women who have had a lot of children tend to be at higher risk of developing what we call postpartum hemorrhage. So that is bleeding from the womb during childbirth. And unfortunately, a few years ago, that was the number one reason why a lot of women died in childbirth, a lot of bleeding after delivering baby. So that is something that is a risk factor. Another thing that I touched on just earlier on is other what we call the past medical history. So other conditions that are medical history that you might have before you get pregnant. You might have diabetes. You might find that when you check your BMI, so your body mass index, you might be on the higher side. So that's when you check your height and your weight. There's an NHS calculator you can use and put into that, and you can check. So a BMI over 25 or 30 is considered more of a higher risk. So that can be, and that can also affect your pregnancy. Having cardiac conditions, which just simply means heart conditions, and things. So such things include hypertension as well, having a high blood pressure. These are all risk factors that can make the pregnancy a bit more dangerous and means that it can need more monitoring. And finally, something that we don't talk much about is mental health as well. So if you have any mental health conditions prior to becoming pregnant, the science actually shows that there is a higher risk of you developing a worse, how can I say, a worse episode of that mental health disorder whilst being pregnant, if not cared for specifically. Obviously, these are all risks. They might not always happen, and every risk has a percentage or chance of it happening based on your other factors, such as your, again, your personal medical history, your age, and also your ethnicity and your background. And today we're focusing again on Black maternal health. Why is this important? Forget my typo. The importance of this is because there is an Embrace report, and some of you may have heard it, but there is a national report that comes out every few years that looks like at in the UK at every single maternal death. So that means anyone who is pregnant who unfortunately has passed away during pregnancy or during 42 days after giving birth. And the reason why we look into this is because we don't want women to go through childbirth and unfortunately pass away, because that has a serious impact on the family, on that child who is growing up without a mother, and on the community as well. So this year, actually, sorry, it was last year, the latest report came out in 2025. The Embrace report stated that the leading cause of maternal death, number one, was blood clots. Number two was heart disease, like I was saying before, cardiac conditions. Number three was COVID. Four was mental health conditions, and five was epilepsy and stroke. But today I'm going to focus more on the blood clots and the heart disease, which is something that it happens a lot in our backgrounds as Afro-Caribbean community as well. These figures and these statements always make me shiver. It makes me very sad, but they are true. According to the Embrace report of 2024, Black women are still 2.9 times more likely to die in pregnancy and childbirth and 6 weeks after in the UK. That is a very shocking statistic. This latest Embrace report says that the chances of a Black woman dying in this situation are less than in the past. So the figures have reduced, but it's still twice as more likely to die in these situations than their white counterparts. For the Asian community, the risk is slightly higher than the white counterparts, but nowhere as near for Black women. And that is very worrying. That's why we are today addressing this topic. And we're talking about what we can do from a patient perspective, from a lady's perspective, somebody who wants to also help, or somebody who is assisting someone who is pregnant through their journey. And trust me, it's not only us who need to change, the medical side as well needs to change, and there's a lot that is happening on that side as well to help us. So let's get going. So the increased risk of blood clots is something that Black women are more at risk of, like I mentioned before. For someone who might not know what blood clot is, the image shows you that in a normal person, so when you are pregnant, yes, you might see signs like your feet swelling, your hands might swell a bit, and you might feel like your face is just going a bit puffier. Things like that can happen, and they can be normal. They have to do with how the blood flows differently in your body, because there's a lot of blood flow that needs to go to baby, and your heart sort of works in a bit of a different way as well to accommodate for that. However, when it comes to developing a blood clot, as you can see in the image on the right, what happens is that instead of the blood flowing nicely through your body, it starts to clump up together. So as you can see in the lady on the far right in the image, her leg is sort of swelling a bit, and there's a few blood clots that are just forming there. What that means is that if you think of a pipe and you think of water flowing through the pipe, if you introduce a blockage in the pipe, what's going to happen? This water cannot flow anymore. And it's the same thing that happens in your human body. If your blood vessels, that is the pipe, are blocked because blood cannot flow through, because you have blood clots there, all your, what we call tissues, or your body parts that surround that area, they will unfortunately die. And what can happen from that is that you can develop a few things. If that happens around your heart, you can develop what we call an ischemic heart attack. So that means that your heart is not receiving the supplementation or the oxygen needs to work. So you can have a heart attack. If it happens in your legs, in your arms, or somewhere else, it can cause, again, blood flow not going to that leg, so that part of your body can then start to die off. So it's very serious. If it happens again in your lungs, it can stop you from breathing as well. So it's a very serious complication. And that's why we need to be aware of the signs and the symptoms of this, and make sure that when you are pregnant, if you develop any shortness of breath or any sudden pain in your body and swelling anywhere, that you raise it up with your doctor. This again is another illustration of blood clots and heart problems as well, just making sure that the message is driven home. Another leading cause of maternal death in the Black community, apologies for the slides just moving, is postpartum hemorrhage. So, apologies, with a postpartum hemorrhage, what that means is, like I mentioned before, bleeding severely after having delivered baby. The reason that can happen is because your womb, instead of contracting, it is quite relaxed. So all the blood that should stop flowing flows, instead of stopping to flow, it flows quite a lot, and it gushes in minutes. This is we call an obstetric hemorrhage emergency. If that happens on the ward, you would see that the buzzer will go off. So when I'm on call and I'm doing a late ward shifts, the buzzer will go off, we'll go to a room, and they'll say major hemorrhage or postpartum hemorrhage. And what happens is that everybody is rushing to the room, hands on deck. Everybody's trying to stop this bleeding, giving medications, giving injections, and trying their best to stop any major blood loss from happening. Within minutes, your blood loss can go from 1 liter to 2 liters and then 3 liters. And that is catastrophic because our body carries about 3 liters of blood anyways in our bodies. So you can imagine losing all of that straight after childbirth. It's quite serious. So we need to be aware of risk factors that put us at risk of developing this and things that we can do ourselves to help with that. At the moment, there's a lot of things that have been put out in the media, and essentially there is a charity called 5x More. Some of you might have heard of it. 5x More is a charity that talks about or that highlights the experience of Black women, especially in childbirth and just antenatally, so in the period when they first discover they are pregnant, all the way to childbirth and also postnatally as well. Because these are some of the things that they have picked up from the latest report. And it says Black women are still being ignored from antenatal appointments to postnatal care. Women described having to push to be believed, especially when in pain or distress. That is a very sad thing to hear. And it's something that we're trying to address, like I said, from a medical perspective, but we need to also do our best from our patient perspective to try and advocate for ourselves. Poor communication, limited empathy persists. Women describe care that felt rushed, impersonal, or dismissive, with limited opportunity for shared decision making. Now hold that thought of shared decision making. We'll come to it later on. This is 5x More. This is the charity that I was talking about. So based on their research and based on their evaluations that they have done of women's experiences during this period, they have set out a few recommendations. So one thing it was to improve the access to the complaint system. I don't know if you've gone to hospital before and you've heard of PALS, Patient Advice Liaison System. Unfortunately, we live in a generation where a lot of people, it seems that sometimes if you're a patient, if you don't try to escalate things further, your concerns will not be heard. And it's very sad to hear, and I see it day in and day out when I work. There are some people who will escalate matters which may not need escalating. But there are also a lot of Black women who I see who don't like to escalate things. They don't like to challenge the doctor when they come in. If they're in labor, or if I'm sure obviously labor is a very stressful period, but if there is a decision that is being made about the care of your child, or whether they want to rush you for a C-section, usually there's no questions asked. Usually what I see is from a lot of Black women is a statement, whatever you think is best, whatever you think is best, it's okay. And in some occasions, I do understand where that's coming from, but then I look at the white counterparts and I look at how much resistance and how much of a fight they put up, how much they would complain even if they don't have pain relief on time, how much they would kick off, and no one can do anything but just try their best to meet their needs. But because they're being very loud about it, they get what they want, whether it's what is recommended or what is not recommended, just because of a mixture of them being quite persistent about it, them and their partners, or actually them trying to escalate things through putting a complaint about the service, which it shouldn't, but in some cases it does work in a way, a roundabout way, to make things work to their own benefit. So that is something that was highlighted. In terms of how we can use this moving forward, I think that every woman who goes into hospital should be very, how can I say, just quite knowledgeable of the process of complaining about the service if there is anything that does not go to meet their standards of care. That's basic standards of care. You shouldn't suffer in silence and those experiences. I know we have a lot of experiences in our culture, in our communities, but they need to be raised up. Until there's ink put to pen ink with the paper, sorry, it's like it never happened. It just carries on being a story that is shared. But when there's physical evidence about it, that's when we can escalate things. That's when we can go to government and say, this is what is happening, this is the evidence, and things need to change, and it can help us to drive change. So don't feel scared to raise up your voice and complain about anything that's not quite right. In terms of this is for doctors mainly, you try and support early diagnosis, so spotting diseases and conditions that might affect a pregnancy in a bad way. So like again, identifying the risks, and also some of the recommendations include supporting informed consent. And I want to just drop a question here, and you don't have to answer me right now, but just think about it. How many times have you gone to the hospital to see a doctor or to have a procedure done, and you signed a consent form and you didn't fully understand what was being said? Just think about that. A lot of women, I know there's sometimes a language barrier for women from a black, just not black, or say different ethnicities backgrounds. Some women might not be fluent in English, or they might not be able to understand the full complications, the risks that are implied, but yet they sign anyways. Once you've signed the consent form, what you're saying is that you have understood every single thing that's been written on that paper. And it means that if you go into this procedure and there's any adverse outcomes, you were already being warned about it. So therefore, there is no blame that has to go to the healthcare team. Now, I'm not trying to encourage a blame culture, but I'm trying to help us to understand really if there is something that we don't fully understand about the process of, again, pregnancy, labor, delivery, we should be asking those questions, and we should not be signing anything until we fully understand what it is we are signing, because there are implications of it. Okay. A lot of the other advice that has been given, or the recommendations that 5 gave, were mainly about just championing care before, during, after pregnancy. So making sure people are aware, like we're doing today, that a lot of women are aware of what things are in place to support them, and what should happen and what should not happen, so they can then raise up and speak up their voices when things don't go quite right. So I'm going to take a few minutes to talk about labor and delivery. So with this section, what I'm trying to portray is the usual events that would happen on a normal, I would say normal, there's no such thing as a normal delivery or normal birth anymore, actually, but on an expected labor and delivery journey. And I'm sure that a lot of women would probably agree that they've not had quite that same experience, but some way, somehow, just bear with me. So there are 3 stages of labor. And actually, before the first stage of labor, there is something called latent phase. The latent phase is when you are feeling contractions, you're pregnant, you're however many weeks you feel, and again, sorry, I'm not mentioning preterm deliveries or any other situations where you're delivering before 37 weeks. I'm talking about your standard, non-complicated, delivering about 38 weeks plus pregnancy. So you're going to latent phase. Latent phase is usually where you start to have contractions. You start to feel these contractions in your womb. You might feel like Braxton Hicks. Braxton Hicks, all it is basically fake contractions. So you feel them, but actually when you put on the monitor, that is the CTG, the belt, nothing is picked up. And they're not quite palpable, these contractions. So you feel your tummy go hard, but you can't actually fully feel these things. These contractions can be irregular, so they can happen maybe once every half an hour, twice every half an hour, once every few hours. So when you come to hospital in that situation, you go to see a midwife, they might tell you, you're not in labor yet. Maybe go home and come back later. Now, I'm going to hold that thought there, and I'm going to come back to it later on after explaining the rest of this diagram. So at the beginning of labor, that is stage 1 of labor, what happens during that is that your cervix starts to relax and it dilates. So you can see from the diagram, baby's here, this is your cervix, your vagina just out here. So essentially, this is the passageway through which we will pass through to come out. And the beginning of labor, actually, your contractions are more established, we call established. So that means that they're more regular. So about 3 to 4 contractions in every 10 minutes, and you're feeling them. You're feeling them quite a lot, actually, usually. However, in Black women, again, we might not feel them. Or in somebody who's had a few children before, you might not feel these contractions that much. So usually around this first stage, you'll be about 3 to 4 centimeters dilated. The next stage of labor is when essentially you go anytime between the 4 centimeters of dilation to the birth of baby. So as many of you already know, you have to be 10 centimeters dilated before you can safely push baby out, because that is the maximum dilation that you wait for. So the cervix is completely out of the way, baby has nothing obstructing him or her passing through. So when it comes to this between stage 1 and stage 2, there have been a few studies that have shown that, especially in Black women who have had children before, they might not take long to go from stage 1 to stage 2. That process might be very quick. And this reminds me of a lady who actually came in, of Ghanaian descent, a patient who I had, who came in, she was in labor, but unfortunately, the team didn't believe that she was in labor because she seemed quite comfortable. She was quite in pain, but nothing was being picked up by the monitoring. So they thought, oh, maybe she'll deliver maybe tomorrow or maybe later on the week. And I kid you not, between the time that she came into hospital, within 4 hours, she had delivered a baby. She had to be rushed to the labor wardroom because no one believed that she would have been able to give birth that quickly. Why does that happen? Misconceptions. For some reason, when Black women miscarry, they are in pain. For some reason, people don't tend to believe that, or they tend to advise to just be strong and tough and figure things out. That, oh, it's okay, be strong, you'll be fine. Meanwhile, there's a lot happening during this time. So one thing I'm going to advise any Black woman is to make sure you advocate for this. You make sure that you actually speak up and just let people know that your midwife or healthcare professional know these contractions are getting stronger, they're getting heavier. I'm really, really sure there's something that's changing, something that's happening. Sometimes we do have timelines of when to examine patients, do a manual examination to check to see how dilated you are. But if there's any concerns or anything else, or if you raise any concerns, the healthcare professionals are well within their rights to examine you before that set time. So don't feel like you can't get an examination quicker if you feel like things are progressing much faster than the technology is telling us, because you're the one seeing the contractions, you're the one seeing the changes, okay? The first stage of labor is about delivering the placenta. So that's your afterbirth, basically. There's 2 ways that you can do this. You can do an active stage, so it means that you can get some injection in your thigh that helps with removing the afterbirth, or you can wait about an hour and just wait for your body to naturally push it out. So these are the whole stages of labor. Easier said than done. There's a lot of hours that pass in between these different stages usually. And during this time, what can you do? How can you look out for yourself? How can you protect yourself? And how can you make sure that your needs, concerns are actually met? Communication, like I said before, communicate, communicate, communicate. Don't be shy. Even if you're being dismissed, communicate. Raise it up, raise it up. Keep saying, I feel in pain. I feel this. It doesn't feel right. Something doesn't feel right. I've been pregnant before. This doesn't feel right. This, that. Don't get tired of saying it. I know it's hard because you're in a vulnerable position and you are also in labor. Being in labor itself, your mind is all over the place. Ideally, you shouldn't even be the one to raise these concerns. As soon as you say something's not right, everybody should be on their feet trying to figure out what's not right. But I'm giving this talk to empower you and also empower any birth partners that you may have to also speak up and let the healthcare team know that this is not right, that this and this and this needs doing. to build that communication. I want to quickly talk about pain relief during labor as well. There is a lot of misconception I found with a lot of Black women. There are three main pain relief options that are given once you're in labor. That is gas and air. Sure, most of you have seen it, and you suck on that device as the lady is right now. And essentially, the main benefit of that is that it's quick and easy to use. So before about 30 seconds before you feel a contractions, that mean as you start to feel it build up, you suck on the gas and air, and then it starts to take effect, and it makes sure that you don't feel that much pain. And then it leaves your system very quickly. As soon as the contractions are, usually just leaves out. It's very short-lived. The cons of it, so the downsides of it is that it can make you feel sick, make you feel dizzy, sleepy, and you can have a dry mouth as well with it. Sometimes what happens is that a lot of women come into labor and they think, I don't want any needles, I don't want any injections, I just want to do gas and air. And that there's nothing wrong with that. But gas and air might not help your pain level, or it might make you so sick and dizzy that when people talk to you, you don't even know what's happening. You're just in and out of it. And again, you don't know how long you've been in labor for. So if you continue with gas and air only, there's a risk that you might actually have, you might become very sleepy and very drowsy to the point where when it comes for you to push, you might not be able to push as effectively. So that's something to bear in mind. Gas and air works really well, but there are other options as well to consider depending on what you want. The next option is pethidine. So pethidine is an injection. That is a painkiller that is given. Usually, there's also something called diamorphine as well. Pethidine, just pain relief that is given as an injection during labor. It takes about 15 to 20 minutes to work. And also, it does seem to have the good relief. Women tend to have better relief than with gas and air sometimes. However, the cons of it, again, the downsides, again, leads to vomiting, makes you feel a bit sleepy, and also you may feel spaced out. I remember reading a birth story when a lady had pethidine as a pain relief, and you can have top-ups of this, right? And by the end of it, she felt very spaced out. She didn't feel with it. She sort of didn't really get to see what's happening with baby being delivered, and she felt like she missed that precious moment. Again, every pain relief has its pros and cons, but what I advocate for is the fact that you don't have to go through a very painful labor unless you choose to. So these options are there, and they could use in moderation, they can help. The epidural is probably the thing that I think most Black women are scared about, having an epidural. Having an epidural is essentially injection in your back, and that is not to be confused with a spinal. When you go for a cesarean section, they give you a spinal. It's an, again, injection in your back of the cesarean section when you go to a theatre, but it goes somewhere else in your body. So it makes your legs very heavy. You can't move your legs. Make sure that you don't feel any pain from the waist below when I do the operation. An epidural is given in the room, and usually what it does is that it helps to manage the pain relief of your just contractions basically. Again, the epidural, when it's in the right place, it works well. 90%, it's 90% effective according to the Royal College of Anesthesia. So it is very effective because it stays in your back. So what they do is that they put a needle inside your back, they put a tube in there, and there's medication that is delivered through that tube. In some trusts, you can even have a button yourself that you press and you can get a top up of that medication yourself. Or if it's not working well, they can try to just give you a higher dose as well manually. However, the cons of it is that obviously there's an injection going to your back. And again, you can get some headaches maybe after it's been put in, maybe signs of fever, or you may feel sick. You might have some low blood pressure, general itching, and difficulty passing urine. So these are all things that the risk of this happening about up to 30% chance. So if you take 100 people, about maybe 30 people or less will experience these side effects. However, something I need to be told about, and your anesthetist will tell you before he or she starts to put the injection in your back. So another thing to note is that the epidural can also not work well, and it might just go to one side. So you might feel the contractions only on one side of your body, not on the other. This is very important that you also are very vocal about it. that you tell them it's not working well. Can you please check it? Sometimes they can try and modify and change things around so that they can introduce a medication on the other side as well. So don't suffer in silence, essentially. That's what I'm trying to say with this. Delivery methods. There's a few different delivery methods we have here in the UK. I always put this picture up because I always think about this whenever I talk about this delivery methods. It's called an assisted vaginal delivery device, and it's called a vacuum device, essentially. It's called Kiwi after the company. So what it is that you get a suction cup put on baby's head, and then as you push, the health professional also pulling on the other side, pulling baby's head to get out. You might then get a cut in your just vagina, just called an episiotomy, to help with delivering baby's head out, and then the rest baby's just pulled out as normal. The other delivery method is forceps. Again, you can see from the image, the ventouse is what I just showed you, the kiwi on the right-hand side. The left side is the forceps. And essentially, it's when I call them salad prongs, they're put around baby's head. And as you contract, as you push, then we also try to pull baby's head out to make sure the baby's head is delivered. And then the rest of the body is delivered as well. And the third option that we all know about is cesarean section as well. So when it comes to which mode of delivery you want, I know that most women want a vaginal delivery. Some people want a C-section. There's no judgment, no shame. But what I advise people to know is the risks and benefits of each procedure. And this is why I go back to the consent form. Consenting and making sure you understand what are the risks, what are the benefits. Sometimes deliver a baby via a kiwi delivery and usually has a bit of a bump on his or her head. That can go down, can be fine. Sometimes it takes a lot longer to go down. You can get a bit of bleeding there. Again, you can go for a C-section, and then afterwards you have a major operation anyway, so you take longer to recover than a normal vaginal delivery. So nothing is perfect, but as long as you know what the risk is and you know what you're able to cope with, then that should be okay. Again, communication-wise, make sure you have that good relationship with your midwife, and make sure you establish your wishes and desires, and make sure that your partner knows how to help and support you as well. And that communication is quite important because when it comes to delivering baby as well, your perineum, so your vaginal wall has been stretched. If it's stretched too much, then essentially you can get a tear as well. And you want to minimize the risk of developing very severe tears or very severe cuts that would make healing and infection a bit more complicated as well. So just to summarize what we talked about, on time is far gone. I just want to really raise this up. This slide is something that I got from a study from Shepard et al. That talks about self-advocacy. So the key message here is, how can I speak up? So whenever you're faced with a choice you have to make that is posed to you by a healthcare professional, I would always advise to ask yourself these three questions. First of all, what are my options? Is there anything else that we can do right now? Do we have to go with this, or is there something else that's available? What are the pros and cons of each option for me? Especially highlight on the for me, because each option might be safe for somebody from a different background, but for somebody who maybe the Black woman already has hypertension, preeclampsia, and other conditions, what are the pros and cons of this specific option for me? You need to be able to understand that. What are the good sides, what are the bad sides, what are the risks, what are the chances of those risks happening, and also how can you get support to help you make a decision that is right for you. So if you don't understand what's happening, can someone break it down to you? If it's a language barrier, can they get information translated in a language that you can read and understand? If you can't really communicate well with the staff, can they actually get you an interpreter to come and explain things to you so that you can understand what is happening? You should never feel like you can't ask these three questions in any setting, be it has to do with pregnancy or something else. You should never feel like you can't ask these questions. I would say every chance you get, always ask them. Nobody can or should just discourage you from doing so, because it's your body, it's your health, and in this case, the health of your unborn child as well. Last thing, just to summarize, Serena Williams, I'm sure most of you know her. She is a famous tennis player. Unfortunately, she also had a bad experience when she delivered her daughter. So the day after giving birth to her daughter, she felt quite breathless, and she was dismissed from her concerns. Again, she lives in America, so a different healthcare system, but quite similar situations, unfortunately. She did complain. She said she was short of breath. She didn't feel comfortable. She didn't feel okay. Now they should escalate this and investigate these symptoms properly. However, she was dismissed initially. She had to persist and she said, "No, I am telling you what I need. I need the scan immediately." In this situation, she was talking about getting a chest scan because she was suspecting that she might have a clot in her lungs. So she had to, so even someone as powerful as her in that situation was also not taken seriously, but she advocated for herself. She said, "No, I am telling you what needs to happen." And sometimes it can feel very forceful, but sometimes that's what it takes to make things happen. She then had the scan and found out that she was right. She had multiple clots in her lungs and she required urgent treatment. All I'm trying to say is that today we've learned about all these risks of pregnancies, all these ways that you can advocate for yourself, and all these things that you should be aware of. I know it's been a general topic, but what I would say is that a free-fall cord is not easily broken. So with the help of leaders such as myself and other healthcare leaders and people like you who have joined in today, and organizations that can to that can help to create these platforms, we can work together to change the outcomes. We don't have to be a statistic anymore, and we can definitely make a difference so that the women of tomorrow do not have to go through these adverse outcomes or through these bad experiences. So let's keep on working together to make sure that we can bring about the change that we want to see. Thank you, everyone.
Thank you so much, Priscilla, for that amazing presentation. And you've covered so much in a short time. And there's lots of very interesting information, and I've made my notes as well. We have got some questions, and I'm looking at the time, but quickly I'm just going to go through what we discussed. So started very nicely with the basic what we call physiology, but what the normal changes that we expect to happen in the body when people are pregnant, and how they differ as well in the Black person, but also what is worse for us. And that's quite interesting when you said, there was that embryo study which showed that we're 2.9 times more likely to die as a result of pregnancy, delivery, and 6 weeks after childbirth. And that's quite an interesting number to think of. So 2.9, basically 3 times more likely
Yeah.
to have problems with pregnancy. And considering that on average we have more pregnancies than the white people, then we can see where a lot of the problem lies. And then quite rightly talked about some healthcare factors, which is very, very staggering words that people have used there, where they feel ignored, where they feel rushed, where they feel, people have been impersonal with them. They feel they've been dismissed, and there's no shared care. And overall, very, very poor communication and involving the mom in that decision-making progress. And then obviously there's no understanding of the diversity that we have amongst us. And even though we're Black and quite, we still have our individualities as well. And everybody's just lumped up in this ethnic minority. So, my struggles is different from an Asian person's struggle is different. And even Asian and African doesn't even really, it just scratches the surface really. And it still comes back to taking people as an individual. I wouldn't look at a white person and say, "Oh, you're a white person and that's what I do." No, I look at you as an individual. I don't look at you as, a Scottish person or somebody from Liverpool. I look at as you. So why should we be looked at as African? That's a very, very, very broad term to use for us, and that doesn't help as well on the healthcare front. And on our side, as the patient, what could we do better? I don't want to put the blame on us in any way, but what could we do better? We could advocate for ourselves more. We culturally we respect authority, and that kind of, in this environment, we then learn how it's not disrespect. It's actually, and as you said, we don't want to generate that blame culture as well, but it's asking out of inquisitiveness, asking to understand what it is that they're doing. If we understand that, we've just said that the people we're facing have lumped us up. They don't understand us. That means they're going to make decisions that does not work for us. So what we then want to do is ask and make sure they're giving us the right options. That is important for us. And also we need to feedback. Exactly. If we don't feedback, people wouldn't know. And I'm going to stretch that a bit further. We also have to start learning to take part in things like research, because if there's a lot of the things, and that's going to address one of the questions somebody asked, that why is the system still not catering for us? Because they don't know about us. We don't tell them these things happen to us. We get upset, we get emotional, we go home, we run to our auntie whoever, Auntie Joan, and that's where it ends. But it needs to go further. We need to moan to the right people, and not moan is putting it down. If something didn't go right, make sure you go back. I had an aunt who died of something not related to gynae the other day, and my cousin was asking me, I wasn't really happy about the care. What should I do? And I said, well, there's PALS, but it is a very long drawn out process. I mean, this lady probably died about 2-3 years ago. The process, the response from PALS was dismissed, and she had to go to take it to the next step. And she's only just getting some answers to getting a meeting. So it is long drawn out, but we have to put the time in it, because if we don't, our children are going to suffer for this. So let's try and put that time in to make sure that the care changes for the people coming after us. It's feedback. Let's think of it as feedback. It's not complaining, it's feedback. If they don't know, nobody's going to do anything about it. And that's the environment that we're in. The language barrier as well is quite interesting. There is language line. Don't feel bad. Never, ever, ever feel bad that you don't understand English. Yes, it's a language, but it's not the end of the world. I mean, there are Asian people who've been here for generations and still don't understand. And they'll come to you asking you, do you speak my language? Like, how am I supposed to speak your language? And that's how bold they've become.
Exactly. Yeah.
That's how bold they've become. Let's not feel shy. Again, it's an African thing, and I don't know, maybe it's the same in the Caribbean, but I know in Africa, especially in Nigeria, if you don't speak English, it's a bad thing for you. You're not educated. So we try and hide this. We don't want to show that we don't understand. If you don't understand, you don't understand. Even I would ask people. I went somewhere the other day and somebody used a word I didn't understand or a terminology, and I asked them. And she was giving me the look. And I asked her, I don't understand what you're saying. Can you tell me in a way I understand what you're trying to explain? Never feel shy about it, because as Priscilla said, this is your body and this is your health, and this is something that can affect you, your mortality rate, whether you survive or you don't survive. So you need to ask and you need to make it known. And if you're not ready to make that decision at that time, tell them, well, I need time to decide. There's no harm about it. It's not as if it doesn't happen, then you've lost out. I need time to think about it. And you go away and ask whoever you need to ask. And then we had the recommendation by 5 times more. We had the summary about how the labor happens and what the pain relief options are, which are really great. And the advocacy again, how we can advocate for ourselves, really, really important. And obviously you went through, so really important, really steps there. And I'm sure people who missed any of that can catch up on YouTube. I do not want to miss the questions that are here, because this is for you and it's not for, it's not for me. I want you to be able to ask your questions and feel comfortable that your questions are being answered. I'm going to start with this one. The NHS says most of their healthcare staff are Black and brown. So why are our experiences still poor?
Wow. Very, very good question. I really like this question because it reminds me of when I went to a health summit a few years ago, and that was highlighted. Even though the workforce of the NHS is very diverse, when you look at the amount of Black and ethnic minority people who rise to the top, is very little. What that means is that we are all part of the healthcare profession in different capacities, but those who make it to the senior roles, the consultants, the senior managers, and all those people tend to be, unfortunately, at the top. It's not diverse. It's not very much diverse there, and that I believe that's where the issue is. So even though we are screaming on the top of our lungs, things need to change, we also need a lot more people who can infiltrate those spheres and those higher levels of leaderships in the rooms where decisions happen, so that there is representation from our side. Somebody can say, actually, from people from my community or from this ethnic background, things are different. And it will take some time, but I believe that that's where the change needs to happen. So that's, in my opinion, why we're having this discrepancy in outcomes.
Yeah, absolutely. So it's not just about more black and brown people in healthcare or going to medicine. It's how many are staying and how many are rising to the top, because it's the system. It's not the people. We have to follow the system as well. So if there's a guideline saying this is what to do, or if my consultant is white and is telling me to do this, I mean, if they're doing something obviously wrong, I would come against them. But if it's something subtle, it's harder for you to challenge it. And sometimes you only challenge it when you have the backing of other people. So yes, we need more people, but we still need more people to stay and to rise. And it is hard. Nowadays, it's easier to get into medicine than it is to rise. So we have a lot of us, and they call it the snowy peak. There's a snowy peak in the NHS as well. So we need more color in that snowy peak as well. Thank you so much. That's really interesting. Now somebody has asked, when my time comes, I want a home birth. I'm terrified about having a baby in hospital. A friend lost her baby during labor, and another baby had life-changing injuries from forceps. Are home births safe?
First of all, let me start by saying thank you for sharing your the stories and just the trauma that your friends have been through. I'm really sorry to hear about that. It's never a great outcome. Hospitals are meant to be a safe place, but unfortunately, these bad outcomes can happen. In terms of a home birth, we actually, I think, in the UK, we've shifted our culture a bit. There used to be a lot more home births in the past than there are now. Now, whether to say that it was safer or not is a different conversation. From what I understand, especially like in my trust, there are still a number of women who choose to give birth at home, and that's fine. There's a dedicated midwife who would be there and help them to guide them through different stages of labor, like I mentioned before. However, what I would say is to make sure that if anything goes wrong, that you have a healthcare professional, some midwife who's qualified enough to understand, to recognize the signs of essentially red flags happening. So your labor not progressing well, maybe its position not being right, or you're not coping well. So whether you can have somebody who's that qualified to be there with you will make a big difference in your outcome, so that as soon as they recognize any red flags, they can come straight through and rush you to hospital. And when you go into hospital, a lot of trusts now, obstetric units, they have what we call a birth center. So essentially, it's a room that is not on the labor ward itself, but it's very close to it. And this room essentially is, these rooms are designed to help you have a very hands-off delivery, so that you can go ahead and have a normal vaginal delivery as long as there's no complications. But you still have a healthcare professional there, midwife there, and if there's any complications, there are doctors right there to help you. That means that we are there just in case, but we won't be actively involved with your care. So I think that would be a safer option if you're considering trying to have a delivery that is not overly medicalized, but at the same time, I'm sure you want what's best for your baby. So to say if it's safe, I would say yes, it is safe depending on your risk factors. It can be safe because it does happen, but just to be aware of the fact that you should have a plan B in case things go wrong.
Amazing. And I will have lots of questions coming in. So if I don't see your question directly, it's because it's probably answered somewhere, and I'm trying to lump up the questions into ones that are similar. So we also have a question about a rise in cesarean section in Black women. Is that something that you've noticed, and is there an explanation for it?
Yes, that's a very fair question. I think so. In terms of rise in C-sections, I think there's been a rise in C-sections overall, regardless of your background. And there's a few reasons that when I was reading, I came across. A few of them would be the maternal choice. A lot more women do not want to labor. A lot more women just want to have baby delivered, and they see it as a quick fix. So they just opt for that. So we have a lot more what we call elective cesarean sections as well. And if somebody comes into hospital in labor and she has already planned for cesarean section, but she is labor and she doesn't want to labor, we'll rush her, upgrade her to an emergency cesarean section. Now, again, if there's any concerns for baby. Now, when it comes to Black women, I would say personally, because of the higher risk, there is a chance that, again, the options are free, either an assisted vaginal delivery, like I said, Kiwi or forceps, or you're having a C-section. So these are very thin lines. What I think is happening is that there's a lot more women who are being induced for different reasons. When your induction process starts, your options become limited. Not to speak against induction, because it is usually for a good cause. So baby is not doing well, or there's any risk to yourself. They're trying to get baby out sooner than later. But once that process starts, if there's any concerns with baby's heart rate drops, or if you feel unwell, with any sense of sepsis infection with mother, then we'd want to rush you to have a C-section so that you don't have these prolonged these other complications from the delivery, from birth. So in terms of Black women specifically, I have not seen it, but it's something that I definitely would circle around to and come back to. But in terms of definitely one factor I have seen is that when there is that option that is raised of having an emergency C-section, there's usually no objections to it again. So whether there's a chance that maybe you could wait a bit or try to deliver baby in a different way, those conversations are not being had. And again, I feel like a lot of Black women are not raising up the question of, is there any other options that we can consider? So I can't say I've seen specifically a Black woman, but I definitely say it is on the rise. And sometimes we don't actually um, know why this is happening until we look back in a few years and we say, actually, this was the reason, that was the reason. So right now, I say we're still the research stage of it. But if I get any updates, I'll be sure to let you know.
Brilliant, thank you. Just wanted to do a big shout out to Pastor B. It's been very, very helpful in, in the chat box with giving more information and supporting the talk so far. There was also a mention, which I'm just going to quickly talk about. I'm not going to ask you the question because I'm sure this is another topic entirely, about the Amos report and, what's going on about it. Again, a lot of the recommendations are quite similar to the ones that we already know about, and some of them are already being addressed by the NHS. Do you have any one-liner to say in addition to that, Priscilla?
I'll say yes, I read that comment. I was very, yes, definitely. It's still, again, the same story, very bad outcomes. However, the Royal College of Obstetricians and Gynaecologists has been involved with not the Amos report per se, but other reports, and they have seen this. And there is a change that is happening. A lot of these changes need to be rooted in, again, the fact that there's a lot of discrimination based on race, a lot of pre-assumptions that Black women don't feel pain, that Black women are essentially more difficult and the rest. So it's trying to deconstruct those myths and those assumptions, those racial biases. So I think that that's where the Royal College is trying to come in to try and change these outcomes.
Amazing, thank you. Very interesting one here. What is the preconception care needed to avoid or reduce this ridiculous outcomes? I think that's one worthy of, a
Yes, definitely.
conversation.
I'm glad someone asked. That's perfect. So when someone thinks about getting pregnant, I would say your pregnancy doesn't start when you become pregnant. It starts probably a year before you get pregnant, because what you need to understand is that your body is as it is. Your body is, whatever you feed it, that's what it'll produce. And one thing that I think a lot of Black people are not really great at doing, unfortunately for my community, is stay on top of their healthcare checks, understanding their body, and just knowing what conditions they might be at risk of developing. So then they don't know, and then they get pregnant, and now it's full blown. This simple pre-diabetic status now turned into gestational diabetes. This mild borderline hypertension that you didn't really bother to look into turns into actually now your risk of developing preeclampsia. So what I would say is preconception wise, definitely try and get a full body check. So just check to see your risk of developing any conditions, high blood pressure, gestational, just diabetes, things like that. And then if you're anemic, really important. Thank you for asking this question, because you've reminded me of something I wanted to say in my talk, which was being anemic. A lot of Black women are anemic, and what can we do about it? Iron tablets, iron supplements, your diet, iron-rich foods, leafy greens, your vitamin C supplements, those things, they're very important because you think about it, if you go through pregnancy and childbirth and your blood count drops even further because you're bleeding, you will be at more risk of needing a blood transfusion or more intervention. But if you can manage these things before you get pregnant, then again, it reduces the risk of, first of all, your baby having problems with growth, and also of yourself during childbirth needing any extra intervention. So I would say definitely read into that before you get pregnant, and be aware of the signs of, again, developing a blood clot or developing any issues like being breathless, chest pains, things like that. Don't take it lightly. Make sure you understand what that can lead to. Another thing is there's a resource called Tommy's Notes, but essentially it's a guidelines to research charity that has been set up to try and investigate and help women have a better positive outcome in pregnancy. So I would say is definitely try and read those guidelines. Those guidelines tell you about what to look out for in different stages of your pregnancy. A lot of white counterparts patients, they'll read through those things, they will know what to look out for, and it puts them at an advantage. So empower yourself with that knowledge. If you have your pregnancy white book, you might have a page, that says, reduce fetal movements. What is it? What does it look like? What does it feel like? Read it. Don't just let them give you a leaflet and then you go home. Read it, inform yourself. So a lot of it's while reading, inform yourself, and then make sure that you just know what to expect and what red flags to look out for so you can raise it up with your healthcare professional.
Amazing, thank you. And as a GP, I would add to that, one of the other things that you could do, and I've had patients certainly coming to do that, is to speak to your GP about having blood tests when you're planning to get pregnant as well. You don't have to have a problem to have a blood test. You could have a blood test if you still want to just make sure that all these things are in place, so your iron levels and your blood count and things like that, especially if you have any family history or personal history of any problems in the past. It's not a problem if you have a blood test, or you can get them done privately because you know what the outcome is going to be to you. So yes, the preconception care on the NHS is not well defined, and it's still personal, it's still patient-led. So if we don't see you before then, nobody knows you're planning to get pregnant. The other thing about planning pregnancy as well is, as soon as you're thinking of getting pregnant, start to use your multivitamins as well. So you can either get just plain folic acid, it's cheap, or if you have more money to splash around, then you can use the more expensive pregnancy multivitamins. But the folic acid is the most important one. So I always tell people, sometimes, I want to stop my contraception, just start using your folic acid, right? That's the the basic minimum medication that I would suggest to use. Now we're going to wrap up shortly, but one last question, and we've had two along this theme, and it's all about advocacy. And I thought, with your experience, Dr. Priscilla, I wouldn't want people to go away without getting this from you. So two people have written in about not being heard. So they've raised a concern, and people have not come back to them. So one person, I'm 4 months pregnant, scared my pain won't be heard. How do I speak up without being called difficult? And should I have someone with me at all times? That's one. And I'll say the second one so you can address both of them together.
Yeah.
And the second one is a personal story about I had 2 of my children in a hospital where I was given fairly positive experience. And as soon as I had contraction, I was given a private room, dedicated midwife, and my 2 children were born in a hospital where they waited till last minute dilation to move me to a delivery room. So that's another experience. No dedicated midwife throughout the labor. So she's had a good experience twice, and then she's had another 2 really poor experience. In these 2 cases, it was assumed as a Black woman, I'll be strong enough and not to need pain relief. But I did need pain relief and did need assistance. When I did complain to officials in writing, it wasn't acknowledged. So if we can just answer those 2 together, that would be great.
Okay, so the first scenario, sorry, remind me the beginning. I just got one second.
Yeah, no, that's fine. I will go through that with you again. So she wants to have pain relief. She's scared of pain,
yeah.
and she doesn't know how to speak up without being
Yeah.
perceived as being difficult.
Okay.
Should she have someone with her at all times?
Definitely. Okay. Thank you for that. So these are two very big questions. Again, I'm really sorry that you have these fears, and unfortunately, it is the world that we live in. So in regards to the first comment, what I would say is in your pregnancy book, you have a dedicated section where you can write your birth plan there. So what the birth plan is essentially is your chance, the opportunity to put into writing everything that you would want to happen during your birth and delivery, so labor and delivery. So things like making sure that this is heard, that this is heard, that your concerns or things like that, just writing those down. What tends to happen is that your midwife will to look at those notes and say, oh, okay, this is what you're planning to do, or this is where we're at, so let's try and honor these wishes. The other thing I would say is having a birth partner with you, definitely I'd recommend having a birth partner with you. It doesn't have to be your partner, but any birth partner, depending on the which trust, you can have up to two people with you. Definitely let them know what it is that your plan is, and making sure that if they can't allocate for yourself, you have them to allocate for you as well. The other thing that can happen is if this is something that's causing you a lot of anxiety and a lot of fear, then you could also ask to be referred to a mental health midwife. And unfortunately, when there is involvement of another specific team within the maternity side, then sometimes your wishes are heard in a much better way because you have someone else who's also in a position of leadership to advocate for you. She'll make it be clear that you cannot be, you're just really terrified about this and you would want your concerns really addressed. And you do want, as soon as you're in labor, the right pain relief options and things like that. Then and that is something that can help as well. The biggest thing I'll say is letting people know from now that you're pregnant, so that doctors write it in the notes multiple times. So when they write it, it's written, it's on paper, it should not be ignored. Aside from that, I know that obviously it can be quite tricky to force people to do something when they don't really recognize your pain. But what I would say is keep escalating when the doctors are coming in forward round. Just say, this my pain is not well controlled. I need good pain relief. Mention it as many times as you can, and even say that you've been dismissed. You've been dismissed because what happens is when you're in labor, there are different on-call teams. So the morning team will be different from the night team. That will be different from the next day. So you're coming through different people, and the chances of everybody saying the same thing is, in my opinion, a bit low. So as long as you keep escalating it, saying this is not right, and that this is what I want. Of course, you can put it into writing and escalate things, but that might take a while. But still, I would say try your best just to say your needs are not being met, so you need something stronger. That's your best choice. And to be honest, I would like to believe that when people go to work, they go to work to try and save lives, to help patients get better rather than dismissing them. If you feel like your midwife is not being supportive, ask to speak to the senior midwife. Again, there's a midwife coordinator who is in charge of every midwife on the shift and in charge of every woman on labor ward. Try and speak to them. Ask them, can I speak to you? Can I let you know that this is happening? I'm not happy with this. That doesn't work. Again, doctors are there. Different levels of doctors, registrars, consultants. Ask, I want to speak to the consultant. I want to speak to this person, and make sure that you call them out by their roles to escalate things as appropriately. And I would be very it would be very unusual for them to just say no, we won't give you anything. For the second question, the comments, again, I'm really happy you had two deliveries, pregnancies that were amazing. And unfortunately, one of the things that tends to happen as well is sometimes labor ward can be very busy and you need to risk prioritize people. And sometimes Black women can be put at the bottom of that ladder for some reason, thinking that they can cope with their pain, they don't need XYZ. You should have a dedicated midwife to you throughout labor. That is a requirement. Even if the unit is short-staffed, if the unit is too short-staffed to allow that, the unit should be closing down. So you should definitely have a midwife dedicated to your needs and to your care during labor. Of course, I'm sorry they had to be rushed in last minute to when you were fully dilated, but I would say definitely in those situations it's something that it's pre-planning, right? I always look at it this way. You know that you're in labor, you would get to 10 centimeters at some point, so what care can we put in place? And it's something that you can also raise up with the healthcare team, or when they come for ward rounds, coordinator telling her, you know, XYZ, you can say, oh, my previous pregnancies, I had expedited delivery. I labored very quickly. So I know that I have a risk factor and you need to be able to accommodate for that. And that hopefully should be something that can work. Tommy's, yeah, thank you. You put Tommy's link in the group chat. Thank you, Dr. Falaki. That's what I was trying to address as well. So hopefully this is the beginning, and things will get better as people know how to escalate things properly, and as healthcare workers stop dismissing people essentially. That would be the next steps forward.
Thank you so much, Dr. Priscilla. We have run out of time and I'm trying to answer as much questions as I can in the chat as well. So while they're doing the wrap up from the CAN team, I will continue to answer. And Dr. Priscilla, if you can answer some as well, that will be great. But I will still keep answering them. But the CAN team have put a link there. If you have more questions, feel free to ask them and they can always escalate that to somebody to answer for you. Thank you so much for your presentation today. And it's been lovely hosting this with you.
Thank you for having me as well. It's been lovely. Thank you.
Thank you. That was a wonderful session. As we always know, this very interesting topics that really needed to be discussed within our community. Always have. We needed another hour to be talking about everything that we need to talk about, but it's great to create the safe spaces. Thank you, Dr. Priscilla. First time presenting with us. Absolutely brilliant presentation. Thank you for your time, for your advocacy. And Dr. Falaki, thank you for your support and continuous advocacy of CAN and everything that we do here at Health Tower. Really, really, we can't do this without you. I wanted to share some of our updates regarding what we have coming up. As you know, we at CAN are always up to something good for our community. Hopefully you can see my screen. Should be in presentation mode now. Shortly. Yep. Next week, we have a really interesting session on a time to shine. So it's regarding mental health, understanding menopause and everyday life. We will have Dr. Catherine Sampa Muyeba as our guest speaker, and she will be guiding us through this very interesting topic around mental health and menopause. We also have our upcoming Black Health Inequality Summit on the 20th of April, will be a Monday. I should say this event is pretty much fully subscribed. So if you are interested in joining us, and I don't understand why you wouldn't, do scan the QR code to join. It is free to attend, surprisingly, because it's a full day of events at the Mermaid in London, so a very primary location in London, and it will be a session full of brilliant speakers from all areas, from the health sector, policy sector, meaning government, also from funding, from community organizations. So everyone that wants to be making change within health, particularly for Black people, will be there. So do join us if you can. The theme this year is Equity at the Center of Systems Change. And as I said, event is almost fully subscribed. We're expecting 600 guests, so you can imagine. So it'll be a brilliant day. Do join us. And if you have any access issues, just drop us an email at events@can.org.uk. Not too long after our Black Health Inequality Summit, we'll be back in London for the Black Healthcare Awards. This is an event where we celebrate Black healthcare professionals. As you heard from both doctors, yes, we do have a lot of Black and Brown people working in the NHS, but are they celebrated? Are they given the right opportunities? Are they, given the right spotlight? So, humbly, the Black Healthcare Awards tries to and achieves to do a little bit of that, which is to celebrate and give spotlight to excellent professionals that sometimes do not get seen by the system. So come and join us. Tickets are available. It's a 3-course dinner. It's loads of fun. There is 360 camera, loads of networking opportunities and live performances. So I do hope to see you there on the 4th of July in London. We spoke also about research and about involvement in research. CAN is part of the Black Health Legacy Partnership, and we're really trying to push the message of the importance of getting involved within research. Their research is part of our legacy, is part of what we will leave to for generations to come in terms of their care and improving medicines and so on and so forth. So this survey is a very easy way to get involved with research. It takes 15 to 20 minutes and has to do with the way that you deal with technology and health. So I hope all of you that have an opportunity that scan the QR code and join us collecting this data through research. Thank you. We also, there's a lot of London today. We have a project called Safe Steps in London. It's way more than a year old now. We work with a number of brilliant organizations under the umbrella of Safe Steps to raise awareness regarding sexual health services, advocacy, chaperoning, or prevention, health literacy, all sorts that we do. We do this in the councils of Lambeth, Southwark, and Lewisham. So do get in touch with us through our social media or through the contacts that you can see on the screen. And last but not least, we work with Cadent. Cadent is a gas provider, and we have a brilliant partnership with them, creating awareness around carbon monoxide and other items. But we really are trying to raise awareness within our community that you can have better peace of mind at home. This is not a luxury, it's essential and is accessible to you. We have distributed more than 3,000 carbon monoxide alarms to families across the country until now, and we're looking to do way more of that. So do engage with us. We're actually working in London and Manchester on this project, but if you live somewhere else and you need support, we'll certainly be able to support you. Contact is on the screen. That's it for today. I look forward to see you next week. And thank you so much for engaging today, for your wonderful questions, and for sharing your personal experiences with us. It always resonates with someone else. So thank you, and see you next week.
Whether you joined us on Zoom, Facebook, LinkedIn, or YouTube, thank you for making the Health Hour part of your Saturday. We hope today's session gave you the right dose of health wisdom that you can share with your friends and family. When we share knowledge, we strengthen our entire community. Mark your calendar. Next Saturday, same time. Got a topic in mind? We want to hear from you at health@can.org.uk. Health Hour, hosted by the Caribbean and African Health Network.